Thank you for the introduction, Solange. It's raining heavily where I am, so you may just hear background rain, so don't mind the sound.
It's very quiet.
Okay. Okay. I'm just trying to control my screen. Oh, yes. I'll begin this session by just outlining the expectations. By the end of these sessions, participants should be able to understand the sources of bias and variation in diagnostic test accuracy studies, as well as know the principles and tools of assessing risk of bias in DTA studies, the relevant tools, and finally know how to present risk of bias assessments in reports of diagnostic test accuracy reviews. This slide summarizes the importance of diagnostics in healthcare. Without diagnostics, medicine is blind. We need good diagnostic tests to guide accurate and appropriate and even timely treatment. The various examples of diagnostic tests, and this can range from normal history taking and examination to blood tests, imaging, genetic tests, and so forth. From a public health perspective, now using the example of end TB, we have a scenario where 3 million people with TB are missed every year by health systems. So what do we do about this? One of the end TB indicators is to promote the uptake of new diagnostics and new drugs by more than 90% by 2025. So how do we execute this goal? And to fulfill these goals, which TB tests need to be recommended for uptake? That's a question that can be asked. And then also, which process is needed to recommend the appropriate TB test? I'll give an example of one of the processes. This is an example that the WHO uses. This is the WHO policy process for tuberculosis, where evidence is normally reviewed from the time of identifying a policy change to ultimately formulating and disseminating the policy. Part of reviewing the evidence also considers the risk of bias presented in the evidence, and this guides in presenting the recommendations as either strong or conditional and so forth. Now, why risk of bias assessment? We need to assess the risk of bias assessment to assess validity, closeness to the truth. You also know that not all published and unpublished literature is of good methodological rigor. And we also need to assess risk of bias to influence the strength of recommendations depending on whether the evidence has got a high or low risk of bias. There are various threats to internal validity that can distort the study findings. From the bottom right, at the bottom right corner, we have the study findings, and the top left corner, we have the truth. Various things can distort the study findings from the truth. And this can include random error, systematic error, and confounding. This presentation is going to focus on systematic error, which is another term for bias. Now we're going to narrow down to bias in diagnostic test accuracy studies. Again, what is bias? This is defined as a systematic difference in an observed measurement from the true value. In the context of diagnostic accuracy, bias occurs when the overall estimates of accuracy, for example, sensitivity and specificity, systematically deviate from the real value. Effects of bias, this generally ends up consistently overestimating or underestimating the true accuracy parameters. Now, you need to differentiate the term bias from variability. Bias comes in when there's a systematic distortion in the design or conduct of a study, and variability arises from inherent population differences. There will always be differences in the population, setting, and test protocol. Now, when you fail to appreciate the variability and fail to mitigate the effects of that, you introduce bias. This table summarizes the differences between bias and variability, which you need to know. And you'll find that in systematic reviews of interventions and even diagnostics, When you're looking at investigating sources of what can lead to variation, you always look at general aspects that can introduce variability in accuracy measures, and then specifically items items that introduce bias into the studies that can influence the overall summary estimates of sensitivity and specificity. Now, bias is the systematic error or distortion or defects in the design or conduct of a study, and variability arises from inherent differences in population settings, test protocol, and so forth. If you fail to properly account for variability, you introduce bias. For example, in a population, there are definitely inherent differences, but if you fail to mitigate this, for example, by doing proper sampling, you'll introduce bias into your study. Now, bias will produce estimates of test performance that differ from the true performance of the test. Variability may not lead to biased estimates, but will just introduce some variability in the accuracy measures, and this affects applicability of the findings. How is bias introduced in DTA studies? Two things, in two ways: through defects in the design of the study and through defects in the conduct of the study. I will summarize this by just highlighting the basic design of a DTA study, which is typically a cross-sectional study or a cohort-type accuracy study, where you start with a series of patients suspected to have the disease, not really with confirmed disease, but suspected to have the disease. And all these patients are tested with the index test and then verified with the reference standard, which is the best available test. And then the results are classified to come up with estimates of accuracy. Now, bias can be introduced in either of these sections, from patient selection to how the index test is conducted, to how the reference test is conducted and interpreted, and finally the general patient flow. This table now looks at sources and types of bias as per the domains I've mentioned. For example, under the patient selection domain, you can have spectrum or case mix bias, and this can be introduced, for example, in the study design, where you have a case control study, where you have cases and healthy controls, meaning controls who are healthy, who do not have the disease. When you start from that angle, you're likely to introduce a bias in that, for example, your estimates of specificity, which is the proportion of people without the disease in the population, in the healthy population, that particular estimate parameter will be overestimated because you're looking at a totally healthy population. So your estimate of specificity is likely to be higher than the true value. Also, spectrum or case mix bias can be introduced when you have bias in sampling. When you don't really execute a random or consecutive type of sampling, you're likely to introduce bias. And in this, in a diagnostic, in a diagnostic accuracy study, you want a population that's representative of what you'll see in practice. And in practice, you'll find people who have got a range of diseases, of disease stages, ranging from mild to severe disease. So ideally, you want that mix of people. You do not want only severely ill people or just healthy people in your population. Context bias can also be introduced when you fail to account for disease prevalence. Now, in areas where there's where the prevalence of disease is high, people are likely to be biased in how they conduct or interpret the study findings. Like you're conducting a study, for example, where the malaria incident is very high, and you know that it's a rainy season, it's bound to be malaria. You know, administer the index test, the results are presented and comes out negative. You're likely to be influenced by the background disease prevalence. So it's always important to factor that and try and mitigate that aspect in your study design. With the index test, you can have test review bias when the index test is not blinded to the reference test results. So if you know the results of the best available test, you're likely to be biased. For example, if you know that the best available test will classify this person as sick and your index test gives a negative result, you're likely to change the results of your findings or to misreport because you're influenced by the reference test results. Now, under the reference test domain, you have classification bias, and these are cases where you have an imperfect reference test. For example, in TB, or generally infectious diseases, where we tend to have, where there are normally lots of cases of imperfect reference tests. Well, you want to compare the results to an index test to the best available test. But what do you do when the best available test is imperfect? How do you mitigate that type of bias as a result? Incorporation bias when the index test forms part of the reference test. You'll find in some various study designs when the reference test is imperfect, people also incorporate the index test to be part of the reference test. And this also happens, for example, when you anticipate an index test to be better than the best available test, which is imperfect. Sometimes some people incorporate the index test to be part of the reference test, and that introduces bias. You have diagnostic review bias when the reference test results are not blended to the index test. And this happens, like again, in the case of an imperfect reference test where you're conducting microscopy. So the best available test is microscopy. The index test is a possibly better test. You think, well, you think it's a possibly better test, and then the results differ, discordant, then you end up sometimes misreporting the findings of your test results based on the influence of the other tests. Under the patient flow domain, you have disease progression bias. Ideally, you want the index test and reference test to be administered at the same time. So why is this important? If you administer an index test now and then the reference test is administered 2 weeks later, you're likely to have a disease progression bias. And this happens a lot in infectious diseases where the degree of infectiousness intensifies or decreases depending on the type of the disease. So you want the tests to be done ideally at the same time so that you get a clear estimate of the accuracy of the tests. You can have a case of partial verification bias where you have some patients are verified with the reference test. For example, you can say that in my study design, only people who test positive with an index test will be verified with a reference test. So that introduces bias because those who are tested as negative with the index test don't get verified with the reference test. So that introduces bias. This normally happens in scenarios where the reference test is very invasive and there's really no ethical justification to subject those who tested negative to an index test to an invasive reference test. So some studies tend to justify partial verification bias due to ethical considerations. You can have differential verification bias where different reference tests are used. For example, all the patients are subjected to an index test, and then 50% undergo verification with a reference test A, and 50% undergo verification with the reference test B. So this ultimately introduces bias in the estimates. Then there's also bias due to missing data from the flow, from the beginning of patient enrollment to looking at the results. There could be missing data due to samples getting lost, patients dropping out of the study, and so forth. There's a tool that has been introduced to put all these sources of bias into perspective, known as QADAS2, the Quality Assessment Tool for Diagnostic Accuracy Studies, and this is what's recommended for diagnostic accuracy reviews. So when you're designing your DTA review, please have this tool before you. And it normally summarizes the type of questions that you're expected to ask in each of the domains. And these are the signaling questions highlighted here. For example, under the patient selection domain, you can ask, was a consecutive or random sample of patients enrolled? So you answer yes, no, or unclear based on what is found. The next question can be, was a case control design avoided? And then did the study avoid inappropriate exclusions? So you answer yes, no, or unclear based on what is reported. Unclear is normally when there's when there's no clear information reported in the primary studies, and this happens a lot. And if most of the findings are labeled as unclear, your overall risk of bias can be also judged as unclear. So based on how you design your study, you can answer your questions appropriately, and then come up with an overall risk of bias assessment per domain. This can be high, low, or unclear. Now, with the diagnostics, we do not have an overall score for quality assessment. And sometimes people make the mistake by saying, by presenting that in review findings, by saying that the overall score is 50, is 5 out of 20. That is not recommended, because each particular question has different weights depending on the disease condition or particular setting. So it's kept open, and you're encouraged to present your results descriptively or by using summary graphs, and I'll talk about that later. Again, in the quadrants 2, we also have questions about applicability. Remember earlier I talked about the differences between bias and variability. So under applicability questions, you can again think about aspects of variability and then ask the question, are there concerns, for example, that included patients do not match the review question? So if you had aimed to include this particular type of population, but then what you find in included studies is sort of different, so there's some variation, you can highlight that and in your data extraction tool. So when you're designing your data extraction tool, please always have the quadrants tool in front of you, and this will help you incorporate all these questions into your data extraction tool. Once you have extracted your data for risk of bias, Review Manager allows you to key in all this data into the system. Now, for those who are not familiar with the Review Manager, it's a software tool that's recommended by the Cochrane collaboration, and it helps in just writing up your review and presenting findings. So once you've extracted your findings, you just key them into Review Manager. This is an example of one of the reviews I'm currently working on, where we extracted information and keyed everything onto a Review Manager. Now, based on what you key into Review Manager will automatically generate the risk of bias and applicability graphs. So for this review that I'm currently working on, with the risk of bias assessment, it's largely unclear because most of the items are not well reported. So it's a bit unfair to judge low or high when items have not been properly reported. So for this particular review, the overall risk of bias is generally unclear due to poor reporting. There are lots of applicability concerns. As you can see, it's very red. And this was because we did not really find studies that really met, that really were the best fit for our question. So there are lots of applicability issues that we highlighted in this particular review. So you can summarize the results in the form of a graph, or again, summarize them as individual studies as per the domains. Like for all these included studies, you can see how each particular study scored in the domains. Like for risk of bias for this particular study was largely unclear for all the domains and so forth. Other examples, this is another example of a TB review that was presented. It was clearly reported, and you could see that there's no unclear reporting. So the judgment was either low or high because of good reporting. So this is what you ideally want, because unclear judgments also lead to unclear recommendations, and that's what we try to avoid. This is another example of, again, presenting your risk of bias and applicability concerns in the form of a graph. You can, just to make it clear, some authors tend to highlight the exact number of studies in the review. Like, so when you're going to discuss the patient selection, you can say that, well, in the patient selection domain, about 10 studies presented with a high risk of bias in this particular domain due to these particular reasons. 11 had got an unclear risk of bias due to poor reporting, and majority, 36, had a low risk of bias. So these are examples of just presenting your results in your review as graphs or as an overall summary broken down into individual studies. Now, after you've presented your findings in details in the main text, you need a summary in your abstract. remember that there's really no summary score of risk of bias assessments for diagnostics. So what people normally present in the abstract is just a general statement, like this is like in this particular review, under the main results section in the review, they just say that most studies had a low risk of bias based on what they saw. So majority of the studies were judged as green in the risk of bias graph. So this is what you can say, or you can say most studies had an unclear risk of bias depending on what you find in your judgments. Now, again, from your systematic reviews, you know that evidence does not stop in systematic reviews. This evidence has to be used to make recommendations. And now we come to grading the quality of recommendations. Some of you, majority of you, I assume, are familiar with GRADE, and this tool helps in just coming up with an overall summary of the quality of evidence. And risk of bias is one of the factors that's considered in the GRADE assessment. So again, this is an example of a tool that a review that I was involved in, where we looked at the risk of bias assessment and incorporated that into the overall GRADE assessment, certainty of evidence. Risk of bias assessment was judged as not serious because it was overall the review had got a general low risk of bias. So risk of bias in this particular review was generally low. So it was not serious. And this ultimately had an effect on the overall certainty of evidence. If the risk of bias was high, for example, we'll have judged this as serious. We'll have downgraded our judgment in the GRADE tool as serious, and this will have had an overall effect on the overall certainty of evidence. And why again is GRADE important? This is very important in influencing the strength of recommendations. So this is again an example of a guideline that I was involved in, where we presented systematic review findings to inform the strength of recommendations. So this was for the expert MTB brief test. So the first example is, for example, in adults and children with signs and symptoms of TB meningitis, should expert be used in CSF as an initial diagnostic test for TB meningitis rather than smear microscopy or culture? Now, a strong recommendation was made due to the moderate certainty of evidence for test accuracy. This certainty of evidence considered in part risk of bias assessment. So risk of bias assessment is very critical in also influencing the certainty of evidence, which ultimately influences the strength of recommendations. So that's why it's really important to be quite rigorous in your risk of bias assessment, because ultimately it affects the certainty of evidence in the GRADE assessments and the strength of recommendations, which has got implications in how the guidelines are implemented. So if your guideline is predominantly, conditional recommendations based on low certainty of evidence, you can imagine the challenges in implementing the findings of that guideline. Thank you for your attention. So that summarizes my presentation on risk of bias assessments for diagnostic accuracy reviews. I summarize with just an important tool or resource that you can always refer to when you want to conduct a systematic review for diagnostic test accuracy. There's the Cochrane Methods Screening and Diagnostic Test webpage that that presents all the related resources required to conduct a DTA review. Well. Thank you. Any questions?
Thanks, Eleanor. So if you have a question, please, either type it in the chat box or you can unmute and ask the question. Okay. There's a question from Tamara about, can you clarify about risk of bias for sensitivity versus specificity? Could they differ?
Oh yes, risk of bias for sensitivity and specificity can differ. And again, this also factors in like the domains that you look at. And for example, the patient selection domain. Let me give an example. Like if in your review you included case control studies, and maybe the case control studies controls with healthy controls. So most likely your risk of bias, the specificity estimates will be affected. So in your grade assessment, you can say risk of bias for specificity will be serious, and you highlight why. You can say some studies that were included were case control studies with healthy controls. And with healthy controls, there's a likelihood of overestimating specificity. And with overestimating specificity, you're likely to have few false positives because you began from an angle of a healthy population. So your false positives are likely to be quite less than normal, what you'll expect normal because of your starting point of having controls from a healthy population. So yes, your risk of bias can affect sensitivity and specificity depending on how you recruit or select patients into your study, and that will influence how you grade the patient selection domain for the risk of bias assessment in your QUADAS tool.
Thanks. There's another question from Meenakshi about asking you to please explain the validity concept again.
The validity concept? Is this, I'm assuming it's this slide validity? What?
She says yes.
I also
he says yes, sorry.
This one.
Okay, all right. So threats to internal validity. This is just summarizing or just looking at how study findings differ or represent the truth. So that is what we refer to internal validity, and this is how you look at the rigor of the study. So in study designs, you always look at internal validity, how the study findings differ from the truth, and then you also have external validity. And with external validity, you look at how the findings are generalizable to the wider setting. So for internal validity, you're pretty much looking at what particular factors could make the study findings be very different from the truth. For example, if you're looking at a test, a diagnostic test accuracy study, probably the truth is that ideally, if the test was conducted ideally, maybe the sensitivity and specificity of the test ideally will be a sensitivity of 99% and a specificity of 99% ideally. But depending on how you conduct your study findings, there could be random error due to chance, and the systematic error, how you defects in your study design. So those estimates will differ from what is the truth. So if the truth was ideally, if this test was conducted, you'll have a sensitivity of 99% and a specificity of 99%. But due to now bias or distortions in how you conducted your study, you might probably have a sensitivity of 90 or 80% and a lower specificity just due to various defects in the study findings, or ideally, probably the truth that this new test that you're introducing ideally has got a very poor specificity, meaning you're likely to have you're likely to have many false positives. But then if you introduce a very a biased study design where you start from an angle of a very healthy population, not a population where some are sick and some are not sick, as what you will find in a normal setting. Your specificity estimates are likely to be higher than normal because you have started from an angle of a healthy population. So that's where validity of the study findings come. What aspects in the study design or how you conduct your study interfere with how the study findings differ from the truth? What you really expect should all these aspects be mitigated? I hope I've answered your question well.
Thank you, Eleanor. There's another question from Jacques about how best to mitigate risk when your study necessitates a clinical example and thus degree of case positives, and thus a high degree of case positives.
Could you repeat the question, please?
How best to mitigate risk where your study necessitates a clinical sample and thus high degree of case positives?
Oh, yes. So are we talking from an angle of, and this can happen like in a laboratory study, like in diagnostics, such studies are quite common, where you find that people start from the starting point is that we have a set of samples in the lab, and sometimes you know that, and you may know that some of cases are positive and others are negative. So I know such studies tend to be biased and people tend to highlight that. So trying to mitigate that, let me come to this slide. So in that particular example, bias will be introduced in the patient selection domain, because you have started from a clinical sample where you're likely to have a sample that is predominantly positive. So what some people do is that you factor that in your assessment by saying we start from a case where the sample is likely to be having a majority of positives, and then others try and mitigate that again by introducing more bias. And then some of them also tend to have now try and test the findings again in a sample of healthy controls, so which again introduces bias, and then they present the findings differently. So you'll find that in particular studies, they tend to mitigate that to look at the effect in the analysis point of view, so that your clinical sample you suspect, but you're not totally sure that all of them are positive, but you suspect that there could be predominantly positive. Predominantly positive does not mean 100% positive. So you could start with that particular angle and then have again introduce how do I put it in simple terms? Look at a population of healthy controls or a series of panel with a mixture of controls. So there are various designs which I do not want to go into because it brings into factors, complex analysis, factors which can factor in that. But there are various ways in which you can do that, where again, you're having that population sample, and then you can again have another subset of samples where you also on purpose select a mixture of findings. Like there's one particular study I was looking at when I was reviewing the risk of bias. What they did is it was a laboratory finding study, and they suspected that in this particular study, the clinical sample would be predominantly positive. So what they did is that on purpose, they realized that if they just took the samples as they were likely to have positive cases. So what they did, I think, is that they on purpose in their sampling frame, they on purpose mixed positive cases and healthy cases as they knew. in the sampling frame, and then randomly selected a random sample from that clinical sample. So that's what they did, having a sampling frame where they knew that they got positives and negatives, and then they used a random sample of selecting samples from that. They randomly selected laboratory specimens from that sampling frame. So there are various ways you can do that, so long as you're just very transparent about the method. Maybe later on I could come up with a session where I now come up with I now talk about specific ways of mitigating risks as it has been raised. And this is quite common, especially in diagnostic studies, which start from, which focus on laboratory samples, where you're likely to know that this particular sample is positive and this particular sample is predominantly negative. So there are various ways of doing that. And those are some of the things I'm also noting, and we have noted that in one of the reviews that I'm currently working on. So there are various ways. You just need to know which is the best way that will mitigate the risk of patient selection bias. That's a long explanation, but I hope I've tried to make it as clear and simple as possible.
You have, Eleanor, thanks. There was only one other question from Ghislaine, but it wasn't particular to DTA. He was just asking about great tools for qualitative and quantitative studies. And Tamara has shared some tools for assessing quality of evidence in qualitative studies. I think we should be fine with that. Are there any further questions about DTA reviews and assessing risk of bias in DTA studies? Okay. So then thank you, Eleanor, so much for your time and for your presentation. Thanks, everyone, for participating. And we will be sharing the recording and the slides via email afterwards. Thank you very much and enjoy the rest of your day.
Thank you.
Thanks, Eleanor. Bye.
Thanks, Eleanor. Bye.